I'm your instructor for today's webinar entitled MedDRA Coding Basics. Assisting me today is Sarah Clark. She's one of the training coordinators with the MedDRA MSSO. We are scheduled for 2 hours for this webinar. My experience in having taught this dozens of times is that we probably do not need the entire 2 hours for presentation of the material, but that will leave us with time for questions and answers at the end of this session. This is a basic coding webinar, so my presumption in training this particular topic is that you don't have a lot of experience or, in fact, any experience with using MedDRA for coding purposes. So this is going to be a basic overview of MedDRA and then talking in greater detail about the browser, which is the tool that one can use to select appropriate MedDRA terms for coding purposes. If you are very experienced with coding and have been doing it for years, it may be that you have chosen a webinar that will be too basic for you, and we have an advanced coding webinar available as well. But I'll let you be the judge as we move forward with the slides. Now, as Sarah also mentioned, this is an interactive webinar in that we will use the poll EV slide or application. It's a way for you to respond and for me to see responses, and then we can talk about answers that are provided. We'll use poll EV for just one question early in the webinar, and later on at the end, there'll be 5 polling questions where I'm going to ask you to attempt to code some verbatims that I provide to you. Other ground rules for this are the following. This is a coding webinar, but if you are waiting with bated breath at the end of the webinar to ask me a question about how to code a verbatim that your organization is having problems with, I shy away from doing that because one of the things that I would like you to appreciate is in order to code properly, you really need the proper context to understand everything, including things like the package insert, the availability of coding conventions in your organization, etc. So I'm going to try and concentrate on principles that should help you make better decisions in terms of how you go about coding with the MedDRA terminology. So at this point, I'm going to move forward and introduce myself a little bit more. So again, I'm Dave Richardson. I'm a physician by training. Specifically, I'm an adult neurologist, and I'm a medical officer with the MedDRA MSSO. I've been with the MSSO for about a dozen years now, and I am physically based on the East Coast of the United States in Annapolis, Maryland. This slide is to remind me to tell you that MedDRA is owned by ICH, and because it is a living and breathing terminology that evolves and changes over time, there has to be some support for the terminology tool. So ICH has created an organization called the MedDRA Maintenance and Support Services Organization, or MSSO, and that is our job to maintain the MedDRA terminology as well as to do other things, including giving these kinds of educational presentations on the most efficient and effective use of MedDRA. The activities of the MSSO are overseen by an ICH MedDRA steering committee, and the rest of the slide just describes the membership of that committee, so we don't need to go through that in the interest of time in any great detail, but our activities at the MSSO are being supervised by this steering committee. All right, this slide is to remind me to tell you several things. The first bullet, which is very long, I'll summarize as follows. This is copyrighted material, and ICH owns the copyright. However, with the exception of the MedDRA and ICH logos, you can feel free to use this material in public presentations as long as you acknowledge that ICH owns the copyright. But if you take this material and change it in any way, shape, or form, you should not imply or infer that the ICH either endorses or supports the changes that you've made. The second bullet is legal language, so therefore I'll read it verbatim. The presentation is provided as is without warranty of any kind. In no event shall the ICH or the authors of the original presentation be liable for any claim, damages, or other liability arising from the use of the presentation. And the last bullet refers to third-party slides, and I don't have any in this particular webinar, so we'll skip over that. So what are we going to do today? We're going to gain some knowledge about MedDRA, its scope, its structure, its characteristics. We're going to talk about coding conventions, and then we're going to focus in on a document, a guidance document, ICH endorsed document called MedDRA Term Selection Points to Consider. This is a guidance provided to you as MedDRA users to help you to understand the principles that you should be trying to follow when attempting to code information that you receive in reports. We're going to talk about the MedDRA browser, which is a tool that you can use to be able to search MedDRA to find the MedDRA term that you would like to capture in your database. I'm going to then go through several coding exercises with you and show you how I'm able to find what I believe to be the best coding choices from the large number of terms that are available to you in MedDRA. And then you're going to use the MedDRA browser itself to also try to code 4 or 5 verbatims or reports that I'm going to give to you. And that's where we're going to use the poll EV tool. And then we'll conclude at the end with our question and answer session. Although I may at several points during the presentation just check with Sarah just to make sure that we don't have a long list of questions that have already been put in the checkbox that are appropriate to answer at that point. Now, this is what you want to do with the poll EV tool. In order to be able to open this up, you need to go on the internet, obviously, either on your cell phone or your computer. Go to pollev.com, and you're going to enter as the username MedDRA174, click join. You're going to skip the next screen and then be able to respond to activity. So that's one way of getting access to poll EV. The second is for you to use this QR code. So I'm going to put that up for about 20 seconds. And for those of you who have your cell phones handy and want to scan this QR code and would rather use the poll EV tool by that mechanism, I'll just let you do that right now. I'll put this up a little bit later as well when we get to the point where you're actually going to be coding some verbatims in case you have lost this or for whatever reason are not able to find it on your phone. But this is your second option for being able to access the poll EV tool. Okay, so let's move forward. Let's start with our MedDRA overview. So MedDRA is a clinically validated terminology. When we say clinically validated, what do we mean? We mean MedDRA is a terminology that has thousands and thousands of terms in it. And when we produce new versions of MedDRA, we put them out there for you, our users, to utilize. The clinical validation comes from you looking at MedDRA, new additions, or looking at MedDRA in terms of where things are currently in MedDRA. And there's a mechanism in place by which you let us know whether you think we've made any mistakes in where we place something in MedDRA, or if you think there are things that are missing from MedDRA, there's a mechanism by which you let us know that, a so-called change request. So the validation comes from your ability to add what you consider to be, or request to add what you consider to be clinically relevant terms, as well as to comment on whether you think the terminology as it currently stands is appropriate. Now, the MedDRA terminology is used not only by the regulated biopharmaceutical industry, but also by the regulatory authorities that regulate industry. And the MedDRA terminology is used throughout the entire regulatory process from pre-marketing to post-marketing. Now, MedDRA can be used for a number of different things, including data entry, which is synonymous with coding, retrieval of data, and then the analysis and evaluation of data, as well as the presentation of data. So in today's webinar, we're going to be firmly focused on data entry or coding. So MedDRA allows you to code information by putting it into your database. That's what coding is all about. But there are subsequent webinars that we give through the MSSO where we touch on topics of how do you retrieve it and how do you use it to analyze the clinical safety data that you have put into your database, which has been coded with MedDRA. So where is MedDRA used? Well, let's start out by talking about where it's not used. In other words, things that fall outside of this rectangle. MedDRA is not intended for use in preclinical testing. So whatever you're doing from an organizational point of view with mice or rats or guinea pigs, et cetera, MedDRA is not the terminology for capturing relevant events from that testing. There are others, presumably, that other terminology that exists for that purpose, but because that's not the part of industry that I work in, I cannot give any recommendations on that. But rather, in fact, when you get to the point where you enter the clinical phase 1 of drug or product development, in other words, this is where you give your product to a normal volunteer for the very first time, all the way through the entire development process, where you presumably at some point get very lucky and get your product approved by a regulatory agency somewhere in the world. You now have a marketed product. MedDRA is relevant and used in all of those various phases, phase 1, phase 2, phase 3, and even for marketed products, so-called phase 4 products. Where will you find MedDRA? You'll find it in databases, not only your databases, but also you'll find MedDRA used in regulatory databases. It's used in a number of clinical safety reports and summaries. It's used in the investigator brochure, for instance, that you provide to investigators who are doing clinical trials. Interestingly, when you first start work with a new chemical entity that you don't know much about, the sum total of what you know in the investigator brochure may only be 25 pages long. Sometimes it's less than that. But as you begin to do trials and you begin to accumulate information, specifically side effects or potential adverse events with your drug, that's when you begin to use MedDRA. And that also turns into an expansion in the amount of information that is in the investigator brochure. Other places, the CCSIs, in marketing applications to get marketing authorization, publications, prescribing information. When a physician wants to use the drug and pulls out the package insert to understand what the dose and recommended administration is, they are also going to find things about side effects, for instance, adverse events, and those are going to be MedDRA terms. And the last one I have on this list is advertising, because for those of you who are not within the United States, you might be very curious to know that we have a situation here where when you turn on the television at night, prescription drugs are advertised in commercials on television. And in fact, you will be given a list during that commercial of potential side effects, and those side effects are actual MedDRA terms. So there are a number of places where MedDRA is in use throughout the entire product development process. Now, when someone says to me that they think that MedDRA has done a terrible job at something, in my experience, 9 out of 10 times, that is true because they try to get MedDRA to do something it's not designed to do. So we have a blue circle, and inside of this blue circle are the things that are within the scope of MedDRA. But I think what I would like to do is start outside of that circle and talk about things that MedDRA is not intended for. It is not a drug dictionary. So if you want a drug dictionary, you should use something like Who Drug, which is a product specifically designed for that. MedDRA is not going to have a lot in terms of demographic terms unless it adds some relevance. So MedDRA will have a term, for instance, for male and female breast cancer. And the rationale for that is that the risk factors, or perhaps the histology, or perhaps the cause, or perhaps treatment response may vary between women and men. And so therefore making that distinction is important. Similarly, MedDRA will have demographic terms when appropriate for vulnerable populations like babies, newborns, neonates, as well as for the elderly. So it is not fair to say there are no demographic terms. We're just very selective. MedDRA is also not going to have much in the way of clinical trial study design terms. You're not going to find double-blind, placebo, crossover terms in MedDRA because the use of MedDRA extends beyond just clinical trials, and many people who use MedDRA are not involved in clinical trials at all. Now, frequency qualifiers. MedDRA, for instance, has a term for headache. But MedDRA does not have a term for 6 headaches or 12 headaches or 20 headaches. So if you care about the frequency with which an event occurs, you need to put something in your data collection instrument that quantifies that information, because MedDRA is not going to do that for you. When it comes to laboratory values, MedDRA does not tend to have quantitative numerical values. And there are a couple of reasons for that. One, you can have two laboratories in the same city which have a different reference range for something like serum potassium. So it's difficult to come up with a normal range that all laboratories use, as well as the fact that certain kinds of measurements, especially laboratory measurements, there may be different scales of measurement. For instance, if you're looking at glucose, glucose can be measured in milligrams per deciliter as it is in the United States, but in Europe, it will be millimoles per liter. And so there are two drastically different ranges of values. So rather than get into a situation of trying to give numerical ranges, MedDRA uses qualitative concepts like high, low, increased, normal, abnormal. Similarly, MedDRA does not have severity descriptors in general for clinical concepts. And that is because if you take a case of, let's say, rheumatoid arthritis, you'll get 3 physicians to disagree on whether this is a mild, moderate, or severe case. So MedDRA will describe the medical condition. But if you are interested in classifying the severity of something or tracking the progression of a cancer or a neurodegenerative disease, then my recommendation for you is to identify a validated scale or score that can be used, because MedDRA is not going to do that for you. And in the same way that it is not a drug dictionary, MedDRA is not an equipment, device, or diagnostic product dictionary. So let's look now at what's inside the circle. Well, everyone knows that MedDRA can be used to capture clinical conditions, diseases, disorders, signs, symptoms, etc. But it also can be used to capture things such as the indication for use of a drug or product, investigations, including not only the test names themselves, but results of test names. And this is not only laboratories, but it can be imaging studies as well, or other kinds of investigations. And then this one involves history terms, and that's not only medical history, but also social and family history, which is sometimes very relevant to capture, because it may say something about the risk for a particular disorder or complication occurring. So these top 5 are really kind of patient and subject focused, whereas the others tend to focus more on products and how they're used. So MedDRA has terms related to medication errors. Someone is given the wrong prescription, or someone accidentally takes the medication the wrong way. Product quality issues. What happens if you open up your bottle of pills and at the bottom of the pills are slivers of metal? That may be a manufacturing issue that turns into a product quality issue. Now, sometimes a product quality issue can turn into a medical condition if the patient were, for instance, to accidentally ingest those metal slivers. Not only is there a product quality issue, but there's also a medical condition potentially now to report. MedDRA also has terms for device-related concepts, product use concepts, pharmacogenetic terms. This is a relatively new area just in this sense. When I was practicing medicine years ago, if you as a physician wanted to use a drug, you would take out a book called the Physician's Desk Reference, look the drug up, and it would tell you how to use the drug. And specifically, what it normally would say is start the patient at this dose, increase it by 25 milligrams every week until they either get all better or they have an intolerable side effect. But nowadays, because we are able to and want to pay attention to the unique genomes of individual patients, it is not uncommon for us to see things in the prescribing information that might say, before giving this drug to a patient, you need to evaluate their CYP3A4 status. That's an enzyme that metabolizes drugs. The package may go on to say if they're a fast metabolizer, give them 100 milligrams, where if they're a slow metabolizer, only give them 25. So MedDRA has a host of these pharmacogenetic terms that help with individualized patient treatment. MedDRA has toxicologic terms, as well as a series of queries, which are a list of MedDRA terms that one can use to query a database to see if you have cases of interest. So this whole idea of queries is another topic altogether, but we do have a couple of webinars on data analysis and query building, as well as one on standardized MedDRA queries, that if you're interested in the data analysis part of this, I would strongly encourage taking those webinars because that's the focus. So MedDRA is a terminology, and this particular terminology has 5 layers or 5 levels. These are the 5 levels of MedDRA going from top to bottom. We have system organ class. Below that, high-level group terms or HLGTs. The level below that are HLTs, high-level terms, PTs, preferred terms, and at the lowest level are LLTs. Now, what you can see is as you go down the 5 levels of MedDRA, the numbers increase. We go from 27 SOCs to 300 HLGTs to 1,700 HLTs to almost 27,000 PTs to almost 90,000 LLTs. And these are the statistics for version 28.0, which was released in March of this year. As you go down MedDRA's hierarchy, you get greater granularity and greater specificity. Now, a point that I want to make here is in MedDRA, at the PT level and above, so that would be PTs, HLTs, HLGTs, and SOC level, MedDRA uses proper British English. So if you are trying to look at an HLGT or an HLT, and there is a British spelling, that's what you're going to see. So if you're looking up a fetal concept, you need to be looking with the O added. Or if you're looking up edema, you need to be looking with O added at the beginning of the word. Whereas at the LLT level of MedDRA, you're going to find both the British and American spelling of the concepts. The second point that I want to make is, in general, when one is talking about analyzing data that has been coded in your database, we usually are looking firmly at the preferred term or PT level. This is where medical concepts live in MedDRA. However, today, since we're talking about coding, we are going to be firmly focused on the LLT level, the lowest level of MedDRA, because that's where you go to select your code that you're proposing to put in your database. Now, here's a point that I want to make. We have 90,000 LLTs. So when someone tells me that they couldn't find a term in MedDRA for what they wanted to code, in my experience, 9 out of 10 times, that's because they haven't looked very hard. And sometimes you need to roll your sleeves up and look very hard in MedDRA to find the greatest level of specificity available in an LLT. But that's in your best interest to do so, because you want your database to contain the most specific and most accurate information, because when you go to analyze it later on, if you've left things out, then there's no way to recreate those after the fact. So let's start at the top. These are these 27 SOCs or system organ classes that I talked about. So for anyone who is a medical person, physicians, physician assistants, nurses, you will notice that many of these 27 SOCs, which are listed here alphabetically in American English, are related to body systems. So you would do, for instance, an examination of the heart, or you would do an examination of the eyes, or you would do an examination of the nervous system when you're doing an examination of a patient. But there are also some very unique SOCs in MedDRA that are not organ systems per se, such as general disorders and administration site conditions, or injury, poisoning, and procedural complications, or product issues, or social circumstances. So one of the important things about being a good MedDRA coder is you have to have some idea of what's in MedDRA in terms of categories, and then you'll have a better idea of knowing where to look for an LLT that's going to meet your needs. One thing that you should not fall into is a trap that people fall into sometimes. Let's say your company makes an antidepressant, and that's the only product that you have. And you say to yourself, well, the only thing I need to know about MedDRA is what's in the psychiatric disorder SOC, because our drug isn't a antidepressant. Well, what happens if your antidepressant causes patients to have an arrhythmia? Then you better know where to look for terms related to arrhythmias. What if it causes headaches? Then you better know what SOC to look in for headaches, because that's a concept that you're going to have in your database, presumably, because your drug may be associated with side effects. So your ability to be any good with MedDRA really stems from having some familiarity with the basic SOCs that are there, as well as thinking about how you want to capture concepts. What's the best way based upon the large number of LLTs that are within MedDRA? Now, we add about 1,000 to 1,500 new terms to MedDRA every 6 months with each new release. And the vast majority of those new terms come from you, the users. You tell us about new terms that need to be added. So MedDRA is constantly evolving. And every time I look at MedDRA, I learn something new, because presumably there are new terms that were added in a particular SOC since the last time I happened to look in that SOC. So it's an ongoing process of constantly keeping yourself aware of what's going on with MedDRA, because what you perceive to be a deficiency right now may no longer be a deficiency because of something we added during the last release. So you have to constantly keep an eye on MedDRA, because it's not static, it is an evolving terminology. So let's look at what this concept of 5 levels means. We'll start with cardiac disorders as an example, as a SOC. Underneath that SOC, there are several different HLGTs. So when we start talking about cardiac disorders, and I say, well, what kinds of big baskets can you create that we would put terms in based upon what kind of cardiac disorder it is? Well, we, for instance, could have an HLGT for problems with the heart muscle, or problems with the heart valve, or cardiac arrhythmias. So in reality, there are multiple HLGTs, multiple baskets describing different kinds of cardiac issues. But underneath that HLGT of cardiac arrhythmias, we have several HLTs as well. So an example of a cardiac arrhythmia that would have terms in it in an HLT would be rate and rhythm disturbances. NEC stands for not elsewhere classified. And there are going to be multiple HLTs. So more granularity and ability to put terms in a more specific grouping. Below that HLT, we have PTs. And one of the PTs that we're showing here is arrhythmia. Now, rest assured that there are dozens and dozens and dozens of actual PTs under the SOC cardiac disorders. What we're just showing you is a very narrow snapshot, because it wouldn't be possible to have everything in there. But when I show you the browser later on, you'll get some idea of how large these SOCs actually are when you expand them. And excuse me, and then under this SOC PT, we start to look at the lowest level terms that you use for coding. Now, if I give you any one of the 27,000 PTs that are in MedDRA and ask you to predict at least one LLT that's going to be under that PT, you can say with absolute certainty that the name of the PT itself is going to be captured as an LLT. So it shouldn't surprise you that we have arrhythmia as a PT and arrhythmia as an LLT. But there are others as well, including arrhythmia not otherwise specified, dysrhythmias. How about this one, though? Other specified cardiac dysrhythmias. This LLT is in red here. And literally, when you go into the MedDRA terminology, you will see it in red. And it is red because that's to tell you as a coder that that particular LLT is non-current. A change has been made and it is non-current. And the significance of that is because it is non-current, we do not, repeat, do not recommend that you use that particular LLT going forward. Now, let's talk a little bit more about non-currency. Again, these are LLTs that in the MedDRA browser you will see identified in red. These are LLTs that are flagged at the LLT level. They are not recommended for continued use. They are not recommended because when we make an LLT non-current, it is because we, as in the MSSO, have either added another LLT or sometimes several LLTs that are even more specific. And that's why we make an LLT non-current, to encourage you to use more specific LLTs in your coding. However, even though that LLT is non-current, we never remove it from MedDRA. And the reason is simply, if you want to do retrospective aggregate data analysis and look back at your data from 12 years ago, you need to have in that printout or output all the terms that were available to you at that time, even though some of them may have been made non-current. Now, why would we make an LLT non-current? Well, a more basic answer would be sometimes the rules of MedDRA, or the rules that we create for administering MedDRA, would require a particular LLT to be made non-current because it no longer fits our rules. But more than often, we have made an LLT non-current because it's either vague, ambiguous, outdated, truncated in some way, or maybe even sometimes misspelled. That comes up occasionally as well. So here's the challenge of all those things that I showed you. Let me show that again. Of all of these things, probably the one that you will see most often as the reason why an LLT has been made non-current is because it's ambiguous. The challenge of ambiguity. So here are I and O standing on the road, and walking toward them are X and L. And I says, if they're Latin, they're consonants. If they're Roman, they're the number 40. And O says, maybe they're from the garment district. So what is the proper interpretation of XL? Again, it depends upon the context. Latin, Roman, garment industry. That's why, in general, abbreviations in MedDRA are made non-current because of the potential for ambiguity. So we haven't really done a lot of discussion of coding yet, but I'm just going to try to use this POL-EV tool for a second here and ask you something. Suppose you had a report, a verbatim report that said patient had MI, and I asked you what you thought was worth coding in this report. Many of you would say, well, I would code MI. And now I'm going to open up the POL-EV and ask you, what is MI? And look at the things that now you're going to enter, and they're going to show up in real time. So some of you are, a few of you said non-specific condition. Some of you said MI, as in myocardial infarction. Wait a second and get a few more of these. So the vast majority of you have chosen to code this verbatim, patient had MI, as myocardial infarction. Here's one person that says, I don't know. I would query site. Okay, let's stop for a minute. Patient had MI. The vast majority of you think that that means myocardial infarction, and you are absolutely right unless you're wrong. And in this case, you're wrong. Because here's the point. You have no context to understand what MI means in a limited little segment that says patient had MI. Even if I told you that this report had come from a cardiologist, you don't know whether MI stands for myocardial infarction or whether it stands for mitral insufficiency. If this report had come from a psychiatrist, MI could stand for mental illness. If it came from a vascular surgeon, it could stand for mesenteric ischemia. So the point here is abbreviations can cause ambiguity, because even when you think you know what an abbreviation means, as one of the responders said, sometimes you need to go back to the site and make sure that what you're presuming to be the case is actually the case. All right, so very good. For those of you who said would query cite, that's what I would say to you. There is a term that we would use when we're not sure what is meant by a particular verbatim, and that term is unevaluable event. And that would be the LLT that I would have chosen for that particular verbatim. But as soon as I put that in my database, I'm immediately trying to go back to the source to get more information. Okay, so let's move on. MedDRA has thousands and thousands of written terms, but also every one of those terms in MedDRA has a numerical representation called its code. So the PT, anemia in MedDRA, and you can see here spelled in proper British English, because at the PT level and above, as I told you, British English is used. Anemia as a PT has as its code 10002034. So here's this 8-digit code. Important things to know about these codes. They're non-expressive. What does that mean? It means that if I give you an 8-digit code, just because you hear the numbers, you have no way of guessing whether it's a respiratory term, whether it's a neurology term, whether it's a rheumatology term. And why is that the case? It's the case because whenever we need to add a new term to MedDRA, we just pick the next number. So there's nothing that you can predict about the nature of a term just by knowing its 8-digit code. But this is also a very useful convention, because when you are dealing with individuals in your organization, for instance, data managers or biostatisticians who are not clinical in their focus, they may not understand the clinical concepts and can't be of a lot of help if you were to simply say, I'd like you to go in the database and find all reports of signs and symptoms that go along with multiple sclerosis. How are they supposed to do that? They're not clinicians. On the other hand, if you go into MedDRA and identify the signs and symptoms of interest to you and look up the 8-digit codes and say to your biostatistician, how many 1000739s do we have? And that's how you can take advantage of these codes to have another language to speak with non-clinicians about. And it also is very helpful to use these codes, and sometimes required to use these codes in data fields for electronically submitting information, particularly in certain kinds of regulatory reports. Now, this is a tough one that we're just about to talk about now, which is the whole concept of multi-axiality. We've already said that PTs are medical concepts. The question of multi-axiality comes up for the following reason. If I asked you which one of the 27 SOCs, or if I phrase this differently, if I asked you what organ systems can be affected by HIV, you would think about it for about a second and you would say, well, multiple organ systems. There can be skin issues, kidney issues, there can be endocrine issues, neurologic issues, etc. So sometimes a PT, a medical concept, has to appear in more than one of the MedDRA SOCs. And when that occurs, that a medical concept is in more than one SOC, it is called a multi-axial PT. Now, this is not a trivial discussion because of the PTs that currently exist in MedDRA, and I said there were approximately 27,000 of them. About 40% of them are multi-axial, meaning they're going to be in more than one SOC. And one particular PT is actually found in 8 SOCs. There's a wide use of multi-axiality throughout the MedDRA terminology. So the importance of this is, if you had a PT that's in 5 or 6 SOCs, when it comes time to look at your data, you may be making the mistake as you start counting up cases based on the number of events at a PT level. You may count the same events 2, 3, 4 times because you keep coming across that PT in multiple SOCs. So what we do at the MSSO in a situation like that is we help you by making the decision, yes, this PT is in 4 SOCs, but we have made the determination that this particular SOC, and we will name that SOC, is the so-called primary SOC. And by definition, all other SOCs are going to be secondary SOCs. And so when you are doing your data analysis, typically people are looking at SOCs and the PTs under them that is the primary sock for those PTs. So you're only going to see those PTs one time. And when you're doing aggregate data analysis, it does not allow you to double or triple or quadruple count. So multi-axiality is not a trivial concept. So let me show you what I mean. Here is obesity cardiomyopathy as a medical concept at a PT level. It is actually found in two socks: cardiac disorders. That shouldn't surprise you because it's a cardiomyopathy. But it's also in the PT metabolism and nutrition disorders because of the association of obesity with nutritional dysfunction. So we have decided that in that circumstance, the primary sock of these two is going to be cardiac disorders, and therefore, by definition, the secondary socks are going to be any other socks in which this PT occurs, that those are by definition secondary socks. So this is relevant, obviously, to data analysis considerations, but important for you to also understand that there are duplications of PTs throughout the MedDRA terminology. Here's just a second example as well, where we have influenza, and it is in two different socks: infections and infestations, as well as in the thoracic, or the respiratory thoracic and medial style disorder sock. Infections is primary, and respiratory is a secondary sock. Now, what are the rules for determining this? Well, I'm going to give you the rules, and then I'm going to give you a few exceptions. And this is as deep as this is going to get. If we have a PT that's only in one sock in MedDRA, that's easy. That's a no-brainer. That has to be its own. It has to be its primary sock because it's the only sock in which that PT occurs. On the other hand, if a PT is in multiple socks, we attempt to place or determine the primary sock based upon the prime site of manifestation. So suppose we had a new disease called Google disease, and I'm reading the literature on it, and it says Google disease can cause brain, heart, and kidney problems. But most patients will have a heart problem. It's told me of the three organ systems that most patients are at least going to have a cardiac problem, and then choosing where to select the primary sock there, I would have made it cardiac disorders because the literature supports that as being the prime site of manifestation. There are, however, three exceptions, which is congenital and hereditary anomaly terms are going to have as their primary sock congenital, familial, and genetic disorders. Neoplasm terms are going to have as their primary sock neoplasms, benign, malignant, and unspecified, including cysts and polyps. And any kind of infection or infestation term is going to have as its primary sock the sock infections and infestations. So one thing I want to point about these three exceptions here, it is possible for more than one of these three exceptions to be in play. For instance, it is possible that you have a certain infection that will predispose you to develop a certain neoplasm. For instance, hepatitis C would predispose you to developing a liver tumor or cancer. By the same token, a child can have infections in utero that can produce congenital abnormalities that are present at birth. So what do we do when more than one of these three exceptions is in play? Well, we have a rule that says if a PT links to more than one of the exceptions, here's the pecking order: congenital over neoplasm and neoplasm over infection. And then one last thing in terms of the terminology itself that's important to understand. There are three socks: investigations, surgical and medical procedures, and social circumstances that are so-called non-multi-axial, single axial, uniaxial. You'll hear it referred to in different ways. The whole point of this is when you find a PT in one of these three socks, that's the only place that you're going to find that PT in MedDRA. So it's important to know that these three socks are unique in that all of the PTs you find in these socks are only going to be found in that single location within MedDRA. Okay, so we're going to stop at this point, and I'll ask Sarah, have I gotten any questions so far from the audience?
We do not at this time.
Okay, so let's move on now and talk about coding. because that's really the major concentration here, but we needed to talk a little bit more about the terminology so you can make some sense of it when I open up the browser later on. Coding conventions, what are these? Well, as it relates to MedDRA, these are written guides or sets of principles that help you to use MedDRA accurately and consistently. So these are basically conventions that you should be utilizing to make sure that when you get a case and you select a term for MedDRA coding purposes, that if you get a similar case 3 weeks from now, if you're following the conventions, you should be landing again on the same LLT, because consistency is certainly important. More importantly as well is not only do you want to be consistent in what you're doing from a coding point of view, but you want your coding to be as accurate as possible. And so if you are using coding conventions, it helps, particularly within your organization, that when you are comparing Jane's coding with Mary's coding, that there should be harmony because they were all following the same rules. And sometimes coding conventions are expanded upon where an organization will provide some guidance to you in terms of what do you do if things are misspelled, or what do you do if things have abbreviations, or what if they're acronyms, or what do we do if it's a due to concept like fever due to influenza. And sometimes, as many of you have already mentioned, sometimes your convention, when you see a certain thing reported, is to go back reflexively and query because you need more depth than what you have there. For instance, it would not be unreasonable that if you get a report of chest pain, that your convention is to immediately go back to the site and ask, is this cardiac in nature, or is this chest pain from some other etiology? Having said that, we ask the question, why do we even need coding conventions? Well, it's because when we have coders, they don't all have the same medical aptitude. There are sometimes coders who have a background as a physician's assistant, as a nurse, as a pharmacist. There are other people who may have an undergraduate degree in biology or biochemistry, but they have been coding for 10 years. I'm not making any value judgment on whether one group is more likely to come up with the right, if there is such a thing, code. It's just simply people's aptitudes are variable, so therefore having rules makes sure that everyone is following the same path to get to proper LLTs. Now, the other point is we have consistency concerns, which I mentioned as well. MedDRA helps because you have a lot of different choices, and by having codified conventions of what to do, you're able to take advantage of its specificity and hopefully be consistent in having some very specific LLTs. And also keep this in mind, even if you have an autoencoder, which is a software tool that you allow to do text mining and select codes for you, sometimes the autoencoder is not going to be able to give you an answer. And sometimes the answer it's going to give you is absolutely wrong when you review it. And then you need to be able to go in manually and select what you think is the proper LLT. And having coding conventions that you use will make that process easier. And now to just point out a few of these autoencoder issues. There's a report that said allergic to CAT scan, and somehow the autoencoder selected the LLT allergic to cats. Now we might find that funny, but if no one is reviewing this and you submit 20 reports of allergic to cats in a regulatory document and they look at it, they're going to come back to you and ask, do you have any quality control at all in your organization? Does anyone ever check to make sure your autoencoder is not coming up with wacky things? How about this one? Myocardial infarction in the fall of 2000. The poor autoencoder, yeah, it captured myocardial infarction, but it also captured fall as an event rather than as a season of the year. So yes, autoencoders can and do make mistakes, and that's why manual overriding or overcoding is necessary, and coding conventions are helpful. So what we at the MSSO offer to you is an ICH endorsed document that helps you with coding called the MedDRA Term Selection Points to Consider document. And this is the cover page of what this looks like. This document is found on the MedDRA website, and at the end of the presentation, I'll show you exactly where to find it, but it provides term selection guidance, not only for industry, but also for regulatory purposes. And I was involved in the committee that is responsible for maintaining this document, and many of the committee members were regulators. So this is, again, evidence that regulators do have input into this guidance. And so if you're not following the guidance here, just understand that the regulators who are looking at your information will want to know why you're not providing guidance provided by ICH, which is endorsed by the regulatory committee members that produce this document. The goal of this PTC, or Points to Consider document, is if you use it, it will provide you with principles that should help you to consistently and accurately code so that you are getting the best possible answer and doing it every single time. And if your organization does not have written coding conventions, you as our users are perfectly welcome to use the PTC as your internal coding convention. But understand it doesn't make any sense at all to say it's your internal coding conventions if you don't follow what's in the document. So this document is developed by an ICH, or excuse me, a working committee of the ICH Management Committee. It's updated annually in March of each year. The complete versions are available in English, Japanese, Chinese, Korean, Spanish, and Russian. There are condensed versions available in these languages, and this document can be found on both the MedDRA website as well as the JMO, which stands for Japanese Maintenance Organization website. And the JMO is our sister organization that is responsible for maintaining the Japanese language version of MedDRA. So this document provides you guidance, and sometimes it will acknowledge that there's more than one option for coding a particular type of event or concept. And very often the PTC will then go further and say, these are your options, but we, as in the Points to Consider document, consider this to be the preferred option. And there are reasons why they have made that determination, but you would be well served to understand when there is a preferred option that you use that preferred option. And if you choose to do otherwise, no one is saying that you can't, but you probably need to have written in some kind of document why you took a different approach, and certainly be very consistent in what you do with that alternative approach. Again, this is called the Points to Consider document. It's not called the Things You Must Do document. So there is judgment on your part to be able to accept or refute something that is a recommendation in the PTC regarding a preferred option. And at the end of the document, in addition to its coding guidance, it has some information about versioning, which is specifically a link to the MedDRA best practices, as well as some other links and references. But here are some specific topics that we are going to talk about in the next several minutes that come out of this PTC. And then after that, we're going to move on to actual coding examples, because I know you're sitting there saying, is this guy ever going to get to coding? Yes, we are, but we need to set the table first before we start having our meal of coding verbatims. So let's go through these one at a time. The first is quality of source data. This is very simple, and just to paraphrase this, garbage in, garbage out. At the time that you're collecting data, whether it's on a telephone, off of the internet, or in conversation with a clinical trial site, that is your opportunity to try to get the best quality information possible. That is your time to ask questions to get clarification, because if you don't, sometimes the opportunity is lost. The patient who calls and tells you about a side effect, if you don't get all the information that you should, and you try to call them a month later, their phone may be disconnected. So you need to make sure that you get everything you can. Secondly, when you are creating your data collection documents, whether it is paper forms or data entry that you do electronically, you need to put a lot of thought into what kind of questions you're asking and what kind of data you're collecting. Because if you realize 6 months into a trial that you've forgotten to ask about patient gender, that's now information that was invaluable that you've lost because you didn't put it in your data collection form. So you can never spend enough time getting quality data. But assuming that you get quality data, you now are able to best utilize MedDRA because you can now go look for the most specific thing that you have available to you in the MedDRA terminology. It's also a good idea, even with coding, to have coding reviewed by qualified individuals. And I'm not going to slip on the banana peel of what makes someone qualified. I'm not going to be arrogant enough to say, well, it needs to be reviewed by a physician, because that's not necessarily true, because MedDRA is a clinical terminology that most physicians, unless they've been in industry a while, there's no reason for them to have a good grasp of what's available in MedDRA. So qualified individuals. And then also remember that when you are using autoencoders, somebody needs to make sure that the autoencoder is not having or not putting out crazy output that's making it into regulatory submissions. Don't alter MedDRA. MedDRA is a standardized terminology. When you get MedDRA, it is hardwired. We, as in the MSSO, have already made the determination of what new LLT is going in. And that LLT is going to be put under a specific PT, which is going to be under a specific HLT, which is going to be under a specific HLGT, which is going to be in a specific SOC. And because you don't like the placement, you don't get to change it. If you think that it's in the wrong place, you send us a change request through our online web CR tool and tell us why you think it's wrong. And if you're correct and we've made a mistake, we make changes like that all the time. But if you take it upon yourself that you just don't like where something is in MedDRA and you decide to do things differently, understand that when you submit that data, particularly if you're doing this every single day, that it's being checked by a regulatory agency that has potentially used MedDRA exactly as it comes in a standardized form, and you're going to have a problem because your data is not following that standard. Okay, another general principle, and this is the holy grail of what you have to do in MedDRA. You're trying to find an LLT that is best linked to what's in the verbatim, and you need to make sure that it is a current LLT. So select an LLT which most accurately reflects the verbatim. So you get a report of abscess on face, and you go into MedDRA and you say, oh, there's an LLT abscess, and you select that. You have done a bad job. Why have you done a bad job? Because the report said abscess on face. You took the easy or low-hanging fruit and just selected the pathologic process. But you can get abscesses on the face. You can get abscesses on the neck. You can get abscesses in the brain. You can get abscesses in the lung. And because you've chosen abscess, there's no specificity, even though you knew it was an abscess on the face. So if you had looked a little bit harder, there is an actual LLT for facial abscess, and that's what you probably should have chosen. Also, just make sure that you do not use LLTs that are non-current. You're not supposed to use them because presumably we've added something with greater specificity. You just need to look and see where that more specific LLT or LLTs may be found. So don't develop company-specific workarounds for what you perceive to be MedDRA deficiencies. If you think something is not adequately represented in MedDRA, submit a change request. And sometimes you have to make a decision at that time how to code, and when there's no exact match at the time, the only advice that I can present to you is to use your best medical judgment to select an existing term and try to get a CR at least evaluated to see if there's a reason why an alternative term that you're contemplating would be a better choice to add to MedDRA. Select terms for all reported information. I was raised in the drug environment. My first job was with a large drug company, and therefore we coded everything. Adverse reactions, adverse events, regardless of whether there was a clear causal association. But you also would code things like device-related events, product quality issues, medication errors, the histories that we talked about, investigations, and sometimes indications for use of a drug. So it's more than just capturing medical conditions. So, quick mythology lesson. This is Thetis, and she is dipping her son into the river Styx. And the legend is, if you are submerged in the river Styx, whatever body part you've dipped in the water now has invincibility. And you see she's holding him by the foot, and I'm sure that you know that her son is Achilles. Well, coding has an Achilles heel as well. Do you know what it is? It's physicians. Don't blame us. Don't blame us, please. That's how we were raised. We were raised to take histories, examine patients, and come up with diagnoses. If a patient came in your office and after spending an hour, you looked at them and you said, I don't have the slightest idea what's wrong with you. Have a good day. You haven't done your job. That is what we're asked to do. But in the biopharmaceutical industry, sometimes making a diagnosis is going a little too far because sometimes you're inferring something that you don't know to be true, and you need to be careful not to do that. So don't add information. Here's a report that says abdominal pain, increased serum amylase, increased serum lipase. And you have a physician in your group who looks at the coding and says, well, that's clearly a case of pancreatitis. But the report doesn't say pancreatitis. You don't get to infer that diagnosis. In fact, the only thing that you probably would have coded would have been abdominal pain, serum amylase increased, lipase increased. And then you would have to go back to the reporter or the source and say, I'm sorry, was this a case of pancreatitis, or why didn't you call this pancreatitis? But you cannot infer things that are not in evidence. So this is a list on the next two slides of the topics that are covered in the points to consider document, but related to term selection. I don't want you to memorize this document, but I do want you to have some idea of what's in the index. Because it's important, for instance, for you to know, let's say, for instance, we have a section on exposures during pregnancy and breastfeeding. About once a year, you're going to get a report where there is a side effect being reported in a newborn or a neonate or a baby because they get exposed to a drug through breast milk. And all I want you to remember in looking through this directory is that guy told me something about breastfeeding, and you pull out the PTC to get the guidance that you need to code that particular verbatim. If your drug is for toenail fungus, the chances of you seeing a lot of violent reports, homicide, deaths, things like that, pretty low with a drug for toenail fungus. But once a year, you may see something where something that is suicidal in nature or death occurs, and you need to know there's guidance in the PTC on how to code that. So familiarize yourself with the topics and then go back and actually refer to the document as the need arises. So now I'm going to just, at this point, stop and ask again, do we have any questions that have come up, Sarah?
Yes, we have quite a few. The first one, it says, we speak more of PT and SOX. What about the rest of the levels? How important are they?
Okay, so very quickly, the other levels can be important, particularly from the perspective of data analysis. If you were to take the webinar on data analysis, for instance, we talk about the fact that most people analyze their data by looking at SOX and PTs, but sometimes by looking at your data at the HLT or HLGT level, it'll give you more of a feel for what the actual safety issue is. So those other levels can be helpful. It's just a case-by-case basis because sometimes they can hone in on a very specific understanding of a problem. And other times, because there are going to be a lot of PTs under an HLT, you're going to end up with a lot of noise that you're not interested in. So for that person asking that question, I would say, let's send you, if that's your area of interest, to one of the other two webinars related to data analysis, because those kinds of things are addressed in those webinars. What else do we have, Sarah?
He mentioned talking to clinical site. Is it okay for research staff to use MedDRA to document adverse events?
That all depends upon you as the sponsor, what you've empowered them to do. So you're asking me a procedural process question. From my perspective, I'm not going to try to legislate who you get information from or who's allowed to query or who's allowed to do things. That is a SOP question that your organization would have to define within your environment. You may feel very comfortable having people with certain titles doing things, whereas in other organizations that would be a no-no. What else do we have?
How far back does the MedDRA web or desktop browser maintain non-current terms?
They're there forever. They never get taken out. You have the option when you look at the browser to not see the non-current terms, but I always want to see everything that's in there. But once a term goes into MedDRA, it never gets taken out of MedDRA.
How is a change order presented for MedDRA updates for consideration, and what is the turnaround time for this?
All right, so I don't want to get into that nitty gritty. This is not really what the coding is about, but we do have a video cast on how to use the WebCR tool. You submit it, and if your request is about a PT or LLT, our turnaround is such that you will get a response within 7 to 10 business days. But I'm going to ask that questioner to actually go on the MedDRA website. On the tools, you will see we have an actual video cast telling you how to submit a change request through WebCR. And let's see if we can do a couple more before we move on to the browser demonstration. What do we have left?
Can you provide guidance on reporting falls or MVAs and coding those?
So again, this all depends upon what your coding conventions are. We, for instance, will, or I have seen situations where people, particularly early in the development of a drug, in addition to coding the injury that occurred, they code fall because you do that not knowing whether one of the side effects of your drug may be that it causes an arrhythmia or causes orthostatic hypotension. And that the reason people are in the database now with a broken wrist or a fractured orbit is because they actually fell. And that was the precipitating event. From my perspective, I don't think you can ever put too much information. So when you ask me about putting things in, I put in all the information that I think is relevant. You know, you say motor vehicle accident. I put in motor vehicle accidents, what I was coding, because I don't know why it occurred. I don't know whether it occurred because the person actually had an accident, or maybe they had a medical event behind the wheel of the car. And again, that might be a harbinger that my drug causes people to suddenly lose consciousness. If I start to get a bunch of MVAs and start to realize my patients are blacking out at the wheel of my drug, I want to capture information. So for me, the perspective is more is better than leaving things out or presuming that it's not worth being in your data set. And one more if we can.
One more. It says, what about the terms that say NOS? What does it mean? And what is the difference between the LLT that does not indicate NOS?
All right, so let's talk about that one briefly. When MedDRA was started, it was not started from scratch. MedDRA took several existing terminologies and combined them all into the first version of MedDRA. And some of those early terminologies that formed the basis of MedDRA had what were called unspecified terms in there. It would say something like unspecified neurologic event. And sometimes it would say infection, NOS, not otherwise specified. So those made it into the original version of MedDRA. But with time, we decided that's not very good. We should be able to do better than that. We should not be adding more NOS terms to MedDRA. We should be providing enough specificity in the terms we put in so that continuing to have to use that appendage of NOS is no longer appropriate. But those NOS terms have been in MedDRA, and as I said to you, we never remove a term, so they're still going to remain in MedDRA forever. My only suggestion to you is when you come across an NOS term, you should look around the LLTs around it to see if there's a better term that was added later that has more specificity than that NOS choice. We don't add NOS terms anymore to MedDRA. Okay, let me get going so we can at least make sure that we finish up by 3. And again, hold on to your questions. I think they're great, and I'll stay on the line as long as we need to answering questions at the end. So I want to talk with you a little bit about the MedDRA browser. And the browser is this. When we send you your MedDRA release files, essentially just think of them as a bunch of file folders. And in one file folder, we have a bunch of pieces of paper with all the LLTs, and in another folder is all the HLGTs, and another one is all of the PTs. But nowhere is this reconstructed into the actual MedDRA hierarchy. And that's what the browser is. It's a tool that we provide to you that allows you on your computer to go in there and actually look at the MedDRA browser, look at the hierarchy, and decide what terms you want to select. So we have several varieties of the MedDRA browser. We have a desktop browser, which is what I'm going to use for my demonstrations today. We have a web-based browser, and we have a mobile browser. I'll just cynically say this one was added a few years ago because some of you told us that you wanted to be able to pull MedDRA up on your phone in case your boss called you while you were on the beach on vacation. And my only comment there is you probably need to get a life, but it's available for you if you want to be able to pull MedDRA up. And I'm just being a little cynical, but again, there were people that said it is crucial for me to be able to pull up the browser on my cell phone when I'm not at my desk. I get it. Sometimes it's important enough to be able to do that. But that tool is not utilized as much as the desktop and web-based browser. Both of these browsers, the desktop and the web-based, we've had long-standing versions of, which are called the legacy versions. Recently, we added an additional version of each, a new web-based browser and a new desktop browser. The legacy version still exists. The reason we added a new version of each is some people said, I don't like the interface in the legacy desktop browser. There's too much on the screen. It's distracting. I don't like looking at it. So we created layered new browsers where you don't have everything on the first page, but you need to do clicking to get to where you want to go. Now that's a preference. I continue to use the legacy version because it is familiar to me, and I never found the information on that screen to be all that onerous, and it's easy for me just to be able to find it where I need it. But each one of the browsers requires you to have a MedDRA ID and password. It allows you to search MedDRA's entire terminology, as well as these standardized MedDRA queries, which I alluded to. They're embedded in MedDRA as well. But in order to hear any discussion about the SMQs, you would need to take the SMQ webinar, because that's where we talk about that. These browsers support all the available MedDRA languages. Currently, we have 27 available languages, with others still in development. You can change the user interface to whatever language you're most facile with. And in the desktop and web-based browser, you're actually able to save information from the browser on a hard drive, or actually print it out if you chose to. And there's some other special features as well, including the ability on the ability to see not only primary SOC allocations, but secondary SOC allocations, the ability to run these SMQs, as I mentioned, advanced search options. I'll show you that on the browser. And this last one is called supplemental changes. I won't really touch on that except to say there is a way for you to go on the web-based browser and see the terms that have been approved for the next version of MedDRA, but they are not currently implemented. So you're getting basically a glimpse of the future of what's going to be in the MedDRA browser coming forward. So let me open up the browser and give you just a 5-minute, 10-minute tour of the browser. This is what it looks like. This is the legacy desktop browser. I was always fine with it because I want everything in one page. If I go to a screen and I have to start going to a subpage and a subpage and a subpage, that's difficult for me. I like everything to be where I need to get it. So here we are now in MedDRA. We're looking at the SOC view of MedDRA in 28.1, which was the version released on September 1st. It's in English. We have a number of links here for various things. I'll show you one or two of them. But you have the ability actually to display up to 3 languages at once in this display panel here on the left side. Mine is set right now for default of English 28.1, which is where it comes when I go onto my browser. Now, think of the browser as having the hierarchy here on the left, search function here in the middle, and then two other things that I'll describe a little bit in a couple minutes. Here is the MedDRA hierarchy, all 27 SOCs listed in alphabetical English, starting with blood and lymphatics and going all the way down to vascular disorders. If I were to select any one of these SOCs and open up the SOC, what do I expect to see? What I expect to see underneath it are HLGTs. And when I showed you that slide earlier, I only had one of the HLGTs, cardiac arrhythmias, but I said there were several because you want large baskets. So here's the basket, the HLGT for pericardial disorders, myocardial disorders, heart failures, endocardial disorders, valve, cardiac neoplasms. So these are the HLGTs. I can select one of those, and below that, I'm going to see HLTs. Right? So we had rate and rhythm disorders, NEC. I showed you that one. If I open that, now look at all the PTs that we're seeing. And some of these are red, some are blue, some are green. We don't have time in this coding course to go through each of those. But what I would say to you is this. We have plenty of information available on our website that will exhaustively go through those. The simple line is this. If you see a red box around a PT, it's telling you you're looking at a PT in the only place where it occurs in MedDRA. If you see a blue box around it, it's telling you that it is a multi-axial PT, and you happen to be looking at it in its primary SOC, in this case, cardiac disorders. And if you see a green box around it, it's telling you that it's multi-axial, and the SOC that you're looking at, which is cardiac disorders, is not its primary SOC. Let's go to myocardial infarction. Now, in order to get to, so I'm going to close that up. So those are HLGTs. So here's what I want just to demonstrate for you as well. If I wanted to look up whether there is an LLT in MedDRA for myocardial infarction, I would have to decide which one of these HLTs to look at. And you might be inclined to say myocardial disorders, but you're not actually correct. Because a myocardial infarction is not a problem with the myocardium. It's actually a problem with the coronary artery that sits on the myocardium. Something's blocking that blood vessel, and as a result, the myocardium is a secondary victim of that. So in fact, I would have to look under coronary artery disorders, ischemic coronary artery disorders, and eventually I'm going to find a PT for myocardial infarction, and I open it up, and here is the whole list of LLTs, including some LLTs that are in red with a red box around them, which we already said means that LLT is non-current. So don't use it for coding purposes. Why did we make that non-current? It's ambiguous. And we added at some point all these other terms like myocardial infarct or myocardial infarction that in the context of this particular SOC, that's what that abbreviation stood for. So that's why the abbreviation got made non-current. So that's just a quick look at what happens. And you can do this in multiple SOCs. I could open up neoplasms and again, see the 5 levels of MedDRA if that's what I chose to do, right? And I could do this in multiple SOCs at one time. And when I'm done with my analysis, just collapse all of it. Now, when it comes to searching, there are a couple ways to search. I can do what's called a top-down search, where I think I know which SOC to look in for a MedDRA LLT for coding purposes. So suppose I had a report that said 37-year-old man had cluster headaches. Cluster headaches is what I'm trying to capture. I would then look and I say, gee, you know what? I'm pretty sure that I would look in nervous system. And when I look in nervous system, I get, hey, there's an HLGT for headaches. That sounds promising. And now I have 2 choices, migraine headaches or headaches not elsewhere classified. I would need to know whether cluster headaches are migraine headaches or whether they're going to be in this headaches not elsewhere classified. If I went in migraines, I'd look around for a while and find out that there is nothing there that's going to help me. And then eventually I'd move to headaches NEC, and there is cluster headache. And when I click, I see cluster headaches. So I now know that there's an LLT within MedDRA that I could use for coding purposes. So this was a so-called top-down search where you believed you knew which sock to look in to try to find the LLT of interest. The second way that you could have done this is a so-called bottom-up search, where I go to this panel that allows me to type in a concept that I'm trying to look for. And if I type in cluster headache and I search, it's going to say, hey, there's an exact match, cluster headache. And there are also other LLTs where the phrase cluster headache is contained, including chronic cluster headache, cluster headaches spelled differently with the word reversal, episodic cluster headache, etc. But the point here is I've now shown that there is an LLT, cluster headaches, which is what I wanted to code. And now if I click that and ask it to take me to the browser, it's going to take me back into the browser and show me exactly where cluster headaches is. So in one circumstance, we started at the top with nervous system and worked our way down, whereas the second search was going into a panel and typing in a term and seeing what I got. Now, having done that, here's what I definitely need to appreciate. I need to appreciate that I need to spell things correctly, but I don't necessarily need to spell them in their entirety. So if I were just to put clust and head, and I searched, it's going to give me all the terms in MedDRA that have those little trunks in them. It's not going to give me an exact match because I haven't spelled the whole thing out. But those are the two basic ways. The second thing I want, or the next thing I want to show just before we close the browser for now is, here's a panel that allows me to filter the output to only look in specific socks. So suppose I had a report of ear pain, and I put in pain, and I search. It's going to tell me, yes, there's a term for pain, but I'd be silly to use that LLT. The reason being that I've lost the anatomic specificity. But there are 674 other terms I'd have to look through to see if I can find ear pain. Or I could be smart and go over and say, listen, browser, show me the results again, but only show me them in the ear and labyrinth disorder sock. And I run the search again. And instead of having 674 terms to look at, here's ear pain as an LLT. So I've used that filter. Now it's in yellow right here, and it's warning me, dude, you have a filter on. And unless I clear that filter the rest of the day, any searching that I'm doing, it's only going to be looking in that one sock. So if you use a filter, be sure to deactivate it once you no longer want that specificity. And this final panel down here in the bottom is just anytime you select something in the hierarchy, there's more information provided about it here in terms of where it fits in the hierarchy and some other things that you will find out about if you look at the video cast on the use of the browser. So I'm going to close all of this stuff up for right now, and we're going to move forward and we're going to do our coding stuff. And I'm going to work at a deliberate pace with this because I want to make sure that you see all of this. So what your approach is, you're getting a report. You're trying to decide what to code. You may sometimes code clinical conditions or test results or medication errors or social circumstances or any of these things. It's going to be driven by what you consider to be important, what your coding conventions are, maybe even the regulatory environment in which you're working. So we're going to start with some coding examples. Here's the first report. The patient suffered from an allergic reaction to an antibiotic. Again, the patient suffered from an allergic reaction to an antibiotic. I'm going to try to help you a bit here. When I show you these verbatims, in general, I'm going to underline the things that you really should be focusing on. So allergic reaction to an antibiotic. So what I'm going to do now is go back to the browser. And I'm going to attempt to do this one as a bottom-up search. And I'm going to type in allergic reaction. And I'm going to search. And it's going to tell me that there is an LLT for allergic reaction. I could choose that, but remember, it said allergic reaction to an antibiotic. So maybe I'm also well served by opening up the other 21 LLTs in MedDRA that have allergic reaction to see if there's something more specific. And lo and behold, here's an LLT, allergic reaction to antibiotics. So I did a bottom-up search. I chose the concept of interest, which was allergic reaction, got 21 other results that I looked at to make sure, is there any more specificity? What if I just put in here anti as an allergic reaction, and then I put the truncated antibiotics in searched? It would have taken me immediately to allergic reaction to antibiotics. So that's having enough familiarity with MedDRA that I would have been able to start at the bottom and put in reasonable LLTs and get what I wanted. If you are very good at this, you would have known that this particular term is in the immune system disorder SOC. It's an allergic reaction. And if you had gone just like this tree is showing you and started in immune system disorders, allergic conditions, and then under allergic conditions, allergies to foods, food additives and drugs, and selected that one. And then eventually you got to drug hypersensitivity. And if you selected drug hypersensitivity, eventually you would have gotten to allergic reaction to antibiotics. So you could have done it either way, but this one requires you to have known what SOC to look in, and you may have spent a lot of time going through HLGTs and HLTs before you got to the right one. So that's what I'm going to do with these examples, is take you through them. I'm assuming a lot of you are brand new at MedDRA, and it's not going to do me any good to say, why don't you take 10 minutes and try to figure out what the right LLT is? Because if you haven't used the browser before, it takes some work to get comfortable using it. All right, so we're going to move on to the next one. The patient states he has been experiencing cold sweats, and I underline cold sweats. Again, I go back to the browser. I'm going to type in cold sweat because I think that's the important concept. And I search. Excuse me, I meant to just type in cold sweats, which is what the verbatim said. I type in cold sweats, I search, I get no results. Now I'm stuck because I can't find a match for cold sweats. When it comes to these kinds of words where you have the plural or singular noun, sometimes you either need to remove the S or add the S, because in fact, if I remove the S, I'm now going to search and find that MedDRA has an LLT for cold sweats, for cold sweat. It didn't have cold sweats with the S. So these are some of the nuanced things. If you're trying to search using a verb like feel dizzy, MedDRA may not say feel dizzy. It may say felt dizzy. So again, it's a question of familiarity with the way that MedDRA views things and expresses things. But the key point here was consider either making a plural noun singular or a singular noun plural, and sometimes you will find the term that you were looking for. Next one. Lab results indicate the patient has increased troponin and an increased CPK-MB. The first thing you should appreciate is that we're talking about lab results. So because these are lab results, that would make me think that the answer to this one is going to be somewhere in the investigation SOC. So again, increased troponin, increased CPK-MB. I'm going to go back to the browser, and you notice here that I have two different tests reported, the troponin and the CPK-MB. So I'm going to select two LLTs in this particular case because I don't want to leave either one of these labs out. So what if I go to the browser, clear all of this, and start with the first test, which is troponin. And I select troponin. There is a dead-on match for troponin, but I can't use that because I want to get across the point the troponin level went up. There are 31 other troponin terms at the LLT level. I will open them up, and now what I need to do is scroll through them until I get to the one that is going to help me with increased troponin. And I don't see any terms that start with I, but when I get down here, I get troponin C increased. I can't use that one because it didn't tell me troponin C. It said troponin. So what I basically need to do is scroll down here and use this term, which was troponin increased. The second one you will recall was CPK. And I searched that one. And again, what I'm trying to find is CPK, not just simple CPK increase. That would be leaving information out. It was CPK-MB. Well, there's CPK-MB there, but it's not telling me what it did. And eventually I scrolled here. CPK-MB increased is the correct term. So I would have chosen troponin increased, CPK increased. Now, if you wanted to do this as a top-down, you would need to go into investigations and be able to figure out what type of lab is this, and then go down through the hierarchy. So a lot of times doing a bottom-up is easier if you keep the amount of truncated information very small and then look through the LLT suggested list to add on the qualifiers that may have been in that particular verbatim. How about this one? Here's a guy who's confused, and you can see he's got 3 medicines in front of him. He's looking at instructions and he doesn't know what he's doing. Patient accidentally took drug Y instead of drug X, and he became short of breath. 2 concepts that we're going to code here. One is short of breath. The other one is he took Y when he's supposed to take X. So we'll hold on that second one for a minute and see if we can have some low-hanging fruit to start with. So I'll go to the browser. I will clean everything up so you have a nice clean browser to start with. I'm going to put short of breath. Search. There's the LLT. Exactly as it appears in the verbatim. If you get a 100% match for the verbatim, that's what you choose. So short of breath. So that's the first one. Now, here is a subtlety that I want you to just appreciate. When you start talking about medication errors in particular, it is very, very, very difficult to do medical error searching by doing a bottom-up, because you have to get the phrase exactly right. It has to exactly sync with what's in MedDRA. So here's a guy that took the wrong medicine accidentally. That's a medication error. So for that half of the equation, here's what we would need to do. We're going to go into this this SOC, which is called injury, poisoning, and procedural complications. And in there, we're going to have medication errors and other product use errors and issues. And I'm going to click on that. All right. And under that is an HLT called product administration. Well, the guy actually took the drug, so it's an administration problem. And then when I go into that, I'm going to see all of these things where products, sometimes it's a drug, sometimes it could be a vaccine, sometimes it could be a biologic. Something was wrong, something was done incorrectly about the administration. And eventually what I'm going to find at the very bottom is a PT called wrong product administered. If I open that one up, I'm going to find an even more specific term, not just a product description, but wrong drug administered. And I will tell you that if you were trying to do that as a bottom-up search, you would have to put in part of the word wrong, drug, and administered to be able to get that result as a bottom-up search. So for medication error concepts, you are best served by trying your best to do a top-down, starting with injury, poisoning, and procedural complications, knowing that all the medication error concepts are going to be found in that particular SOC. Okay, let's move on to our next slide. 2-day-old baby was noted to have a mild fever. I underline baby, I underline fever. Why? Because babies are a vulnerable population. So this is one of those situations where if MedDRA has a term with that level of demographic specificity, I'm probably going to want to try to use it. Now, I'm going to go to the browser. I'm going to type in fever. First of all, I have to spell it right, otherwise you'll get nothing. Fever. I search. There's fever. Is there something in MedDRA that's going to help me? Because I would like more specificity. I can scroll through all 197 of these trying to find it. What happens if I put in fever baby and I search? I get nothing. So that's telling me that maybe MedDRA is not using the word baby. What term might MedDRA be using? And this comes with some familiarity with MedDRA, that you will know that MedDRA has the phrase baby in it a few times, but more times than not, MedDRA uses concepts or the words neonatal or newborn. And if I type in newborn, if I type in new, it's going to give me as an LLT fever neonatal, because as far as MedDRA is concerned, neonatal and newborn are synonyms. And here now is an LLT, which is a great improvement over just fever. I now capture the fact that a neonate, meaning 28 days of age or less, has a fever, and that's a big deal. If your 1 year old is at home, or excuse me, your 1 week old is at home with a fever, you probably need to rush in and have that child seen, because bad things happen to young baby brains when they get too hot at that age, because a lot of things are not working well, including the immune system. Okay, moving on. 35-year-old woman was taking drug X to prevent relapses of multiple sclerosis. This is where you need to think. Here's the diagnosis: multiple sclerosis. I know multiple sclerosis is going to be in MedDRA, but when I think about it, what is this drug being given for? It's being given to prevent relapses. What do we call drugs that we give people to prevent things from happening or relapses? We call them prophylaxis. So I'm going to go into the browser, having used my head a little bit, to try to figure out if such a phrase exists in MedDRA. You can't just simply just go in blindly without looking at and sometimes studying the verbatim. If I type in the trunks of multiple sclerosis and beginning of prophylaxis, and I could type the whole thing out, but in the interest of time, you get it. If you use properly spelled trunks, you're going to get to what you need to. There's an LLT for multiple sclerosis relapse prophylaxis. I could have done this differently. I could have typed in prophylaxis, the beginning of the word prophylaxis, and it's going to give me every single term in MedDRA that has that concept. But this is over 200 terms. So by having typed in multiple and the beginning of sclerosis, I narrowed that all down and basically only got the one response. Okay, let's move on. She had a pathologic fracture of the neck of the left femur. Pathologic fracture of the neck of the left femur. This one just involves trying to get as much of this valuable information as possible. She had a femur fracture, but it was the neck of the femur. Not only was it a fracture, it was a pathologic fracture. What is a pathologic fracture? Well, let's say someone has breast cancer that has metastasized to their femur. Because that tumor is in the femur, it's weak. And so they go to step off a curve and their femur fractures. That's a pathologic fracture, because where you experienced the fracture, there was some pathology going on. And so if I now go into the browser, I'm trying to figure out how I can do this. Now, again, femur. I'm going to start with FEM. I'm going to put fracture. And I'm going to search. 64 results. If I scroll through all these 64 results, which is not a terrible number, eventually I'm going to come up with the right answer. And the right answer in this case would have been pathologic fracture of neck of femur. Now, it's not going to have left or right, because MedDRA doesn't care left or right, because that doesn't add much to the discussion. MedDRA will have left or right terms when they're relevant, such as things that happen on the left side of the heart versus the right side of the heart. But in this particular case, not particularly relevant. But you can see I had to go through 64 terms to get there. But if I were to have added more trunk words, you can see that the more trunk words that I add, in this case, neck, it now drops it down to 16. If I put in path, as in pathologic, it now takes me to that one term. So the whole point of these bottom-up searches, you have to get sophisticated with how MedDRA uses its nomenclature, put in some information, but not necessarily paint yourself into a corner with how much you put in there. For instance, if you put pancreatitis, MedDRA is going to give you pancreatitis terms, but maybe you only want to put a trunk of that because you may want to see pancreatic. So again, trunks sometimes get you more than you would get if you were trying to be too exact. It's a balancing act. So now let's go back to our slides. Following the procedure, the patient experienced several days of constipation. This one is not earth-shattering. Clear everything, put in constipation. Search. 16 terms. Any qualifiers here? Well, you remember from the slide itself was following a procedure. Anything here that looks like it's related to a procedure? Yes. Post-procedural constipation. Some of you will say, why didn't you use post-operative? Because what does the verbatim say? It says procedure. And again, your prime directive is as best you can to try to replicate what is in the verbatim. So we would use post-procedural. Okay. Moving on to the next one. Death and other outcomes. The 66-year-old man died from a ruptured aortic aneurysm. I want ruptured aortic aneurysm. I go in here. Beginning of aneurysm, I search. Here are 53 terms. I can search through them. Eventually, it's going to take me to where I want to be, which is aortic aneurysm rupture, or I could help the process along by beginning to type in the word rupture and see what I get. And it would have taken me now to 5 choices to select, in which case you have to now look at which one best replicates, and it is aortic aneurysm rupture. Now, here's a question that people ask all the time. We're going to go back to the slide. I didn't code the fact that the man died. Why didn't I do that? Because death in this case is an outcome or seriousness criteria. It is not an adverse event. So the general rule is that death, disability, and hospitalization are not adverse events. They are outcomes or seriousness criteria. And you do not code them. You capture them somewhere else in your data collection form where it usually says outcome. Died, recovered without sequela, had a permanent disability, et cetera, et cetera. So that's why we did not capture the death concept, because it's captured somewhere else, presumably in your data collection instrument. All right, how about this guy? This is a product quality issue here. It was determined that the product was counterfeit. For this one, oh, sorry, didn't mean to do that. For this one, we're going to go into the browser, and I'm going to try to do this one as a top-down. This is a counterfeit product. When I look through the 27 socks, eventually I say to myself, I think that's probably a product issue. And sure enough, here's the division between devices and products. Well, this was not a device being described, so I'm going to select here. And here at the top is an HLT for counterfeit, falsified, and substandard. And I select that. And what is it going to tell me? Counterfeit product administered. That's not what it said. It says it was determined that the product was counterfeit. It doesn't say anything about whether it was administered to anyone. So that leaves me to land on product counterfeit. And then, in fact, we have this term for product counterfeit. I felt comfortable enough with this one to go down in product issues because I didn't think that a product counterfeit issue was going to be in any SOC other than product issues. Okay, we have a couple more of these, and then we're going to go on to the 5 where you're going to do a little bit of coding. This one is straightforward, the next one. The patient was confined to a wheelchair. I just want to point this one out because it's very simple. If I simply type in wheelchair, and search, I get wheelchair user, which is the best possible LLT. But what I want you to appreciate is that this wheelchair user is in a SOC that most people never look in, which is the SOC called social circumstances. These are not adverse events. These are characteristics of the patient, which may have some relation or association with their likelihood to have developed an adverse event. But sometimes a description of the patient will give you some glimpse into the kinds of medical problems that patients have. So if I open up this SOC, look at what's in here. Age issues, housing issues, environmental issues, family issues, lifestyle issues, etc. So this was under disability issues, where we eventually found wheelchair user. But look at what else is in here. Cardiac assistance device user. That to me means that this person is walking around with a mechanical heart hanging off of a bag off of their belt, waiting for the phone to ring to say that there's a donor for their heart transplant. But because it's in this SOC, which is one of the 3 I told you about, social circumstances, that's the only place in MedDRA you're going to find that particular PT. So if you were trying to query your database to find cases of cardiac disease, you better look in this particular SOC. Otherwise, you're going to miss all those cardiac cases where you're actually describing a mechanical heart. By definition, that person had a cardiac issue. So social circumstances is important for you to look at. Yes, it has things in there like, perpetrators of crime and victims of crime and whether you smoke or don't smoke or not. But sometimes it gives you a glimpse into medical conditions as well. So I'll close that. And then we're going to move on to the last one, which is the pharmacist made a mistake in compounding the medication. Mistake in compounding the medication. Well, it says a mistake. So to me, a mistake is an error. It relates to a medication. And therefore, if I'm true to my word, I told you that you should be using top-down searches for medication errors. And as you will recall, we said injury, poisoning, and procedural complications. And so now we're going to look under medication errors and look at my choices here. Of the choices describing medication errors, the appropriate one is for me to choose product preparation because he was compounding a product. And when I do that, I see a PT for product preparation error. And when I select that, eventually I find product compounding error. Because you may have had great difficulty trying to do it as a bottom up. Because if you kept typing in drug this or drug that, you're not going to get anything because the LLT has the word product rather than drug. So again, medication errors, best to do top-down searches. So this is just a vignette that we're not going to do. I've underlined things just to give you an idea of what your coding conventions may dictate. 75-year-old man receiving drug X for rheumatoid arthritis. I would code that because it's indication for use. Developed symptomatic aortic valve stenosis. That's an adverse event. Past history was remarkable for colon cancer and cigarette smoking. Capturing those because it's medical history. He underwent an aortic valve replacement, surgical procedure. And then he developed a wound infection 3 days post-surgery, a complication, and more specifically, we know that this is a wound infection, and we would then be looking for a post-operative wound infection. All these concepts are in MedDRA But that just gives you an idea of if you are following coding conventions that have you very liberally capturing information, because if it's not captured now, you won't be able to find it later on, you'll be in trouble. So at this point, I'm tired. I've been doing all the heavy lifting. Now it's time for your final exam. So here's what we're going to do. I'm going to show you 5 vignettes. And as I show them, I want you to use PollEV, and I want you to type in what you think is the correct LLT out of MedDRA. If you have MedDRA in front of you, obviously your browser's open. I want you to take a minute or so and see if you can do it. And if not, then I'll show you the answer. If you've never used the browser before, there's no way in the world you're going to get this, because you're going to be too busy trying to figure out what to do. So I won't belabor the point. But after the webinar is over, if you want to look at these examples again and try to figure out how we got there, then you can do that as well. So you're going to use either the desktop or web-based browser. You're going to try to find an LLT. You can either do a top-down or a bottom-up search, but make sure that you only use or propose current LLTs. And in case you weren't on earlier with PollEV, this is how you get on, pollev.com. Type in the username, join, skip the next screen, and it will take you to the activity. And I'll show that again for about 10 seconds here so that we don't run out of time here, if you don't already have it in here. So here's the very first one. She was diagnosed with pneumonia caused by COVID-19 infection. She was diagnosed with pneumonia caused by COVID-19 infection. So I would like you to type in the actual LLT that you think would be used here for coding purposes. So some of you are typing in responses that intuitively you got the concept. You got the concept of you not only want to capture pneumonia, but you want to capture the concept that it is COVID-19 related. And I'm assuming you don't have ready access to the LLTs, and that's fine, because conceptually you're getting what you should, or what you should get out of this. And for those of you who do have the LLT or experienced coders, you're hitting the nail right on the head. The correct LLT in this particular case is COVID-19 pneumonia, because it's capturing not only the pathologic condition, which is pneumonia, but the fact that COVID-19 is the sinister culprit in this one. How about this one? Woman ingested her husband's blood pressure drug by mistake. By mistake, again, I'm sending you down the road of a medication error. Should have cleared that. I had Sarah send me a message to make sure that PollEV was working, so just ignore that. And let's see what kind of responses we get. Accidental exposure. For that person, I would ask, can we do better than exposure? Is there a more specific term? The one that says drug administration. Well, that's possible as well, but there's more specificity. Now we're starting to get a bunch of folks who are landing on the best answer here. Exposure is just too general a concept for me. Okay, so I'm not going to belabor the point, but let's just accidental ingestion of drug. First of all, it's capturing the fact that what happened was an error, it was accidentally done. Secondly, the product type was an actual drug and it was an actual ingestion. Now, sometimes the word that is used will be ingestion, sometimes it will be intake. Sometimes we will have a drug term, sometimes it will just say product. But the important thing is this one allows you to include accidental, swallowed this thing, and it was a drug. The others are not wrong, but there's greater specificity. And that's what I meant about rooting around to try to find the best possible LLT out of the almost 90,000 that exist in MedDRA. This one, pay attention to the spelling. Patient developed hyponatremia, which is a low serum sodium, while hospitalized. Patient developed hyponatremia while hospitalized. Hyponatremia. Correct concept, but you're leaving something out. You're leaving money on the table if you're playing poker. Yes, it's hyponatremia. But first of all, pay attention to how hyponatremia is spelled, because what you see there is an A after the R. It is British English spelling. You should know that from the fact that hospitalized is spelled with an S rather than a Z. So in fact, what we have here is hyponatremia that has to be spelled with the version of hyponatremia that's in the verbatim, which was British English. So you need the one that is TRAE. And secondly, you also are given additional information that this hyponatremia occurred in the hospital. So there is a LLT that does both things for you, and it is hospital acquired hyponatremia spelled with British English. Next one. Nurse noticed that the injection solution had an unusual odor. Nurse noticed that the injection solution had an unusual odor. Product issue is a little vague. It's not giving me any idea what that actual problem is. Someone is saying product odor abnormal. Someone is saying product smell abnormal. So I would direct you back to the verbatim and say which word is used in the verbatim, and I'll show you that in a minute. Okay. Back to the slides. Product odor abnormal. Because again, remember, it said that it had an unusual odor, not an unusual smell. So that's why odor was the choice over product smell abnormal. But this is also another one where you needed to pay attention to spelling, because the British spelling of odor is O-D-O-U-R. So you correctly realize it was the American spelling of odor and used the correct LLT. This is the last one. Here's a suspicious lady checking on what's about to happen to her. Elderly woman complained her arm was tender where she had received her seasonal flu vaccine. Elderly woman complained her arm was tender where she had received her seasonal flu vaccine. So for those who are giving me injection answers, an injection is telling you that something was injected at the site, but I would humbly suggest that vaccine is even more specific because it gives you an idea of the nature of what the substance was. And you're going to find things for pain and discomfort and whatever, but you need to match the verbatim. And the closest match to the verbatim here is what I'm seeing over and over again here, which is vaccination site tenderness. She didn't just get an injection, she got a vaccination, and it didn't say her arm was painful, it said her arm was tender. So that is the best answer of what's available in MedDRA right now. Okay. So at this point, every one of you has a 100-19211, which is the MedDRA term for headache. What did we do? We discussed the scope, structure, and characteristics of MedDRA. coding conventions, gave you a little bit of an introduction to the points to consider document, which I would strongly recommend reading. It has excellent information. It's interesting. You can read it probably in an hour and pick up a lot of coding pointers. We introduced the browser, and we've shown you, or I've shown you how it's used for browsing, and you took a crack at it yourself as well. So these are contact information points that I want to share with you. This is the MedDRA website, our email address for the help desk, frequently asked questions on the website along with the answers. These are the URLs for the various MedDRA browser versions. This is the link to submitting a change request. And we also have a video for that, as I said to you. You already know about the training page because obviously you enrolled in this particular webinar, so you know how to do that. And then support documentation is where you go on the MedDRA website to find those documents. So if I were to open up the MedDRA website right now, how to use, go down to support documentation and look under points to consider documents. Right here is where I'm going to find the points to consider document for term selection. And I would strongly suggest, if you have the time, reading that because it's a wealth of good information. So I'm going to stop at this point. We ran over 1 minute. I apologize for that. Normally, I don't take questions in the middle of the webinar, but this one I thought we should take a few since it's the basic course. And I'm going to stop at this point. For those of you who need to sign off, please do. This whole thing is being recorded, so if you need to listen to questions and answers that were asked, you can certainly do that as well. And if you're signing off, I want to thank you for your time and attention for today's webinar. I hope it's helpful, either in terms of giving you an introduction or pointing you in the right direction with some more advanced principles and certainly resources that are available to you. So, Sarah, do we have other questions that have come in?
Yes, we do. A little bit ago, they said, could you please repeat the term that was used for ambiguity?
The term that was used for ambiguity, if you're asking about what slide, it was the slide related to MI. And the example there was given because an LLT that is ambiguous, like abbreviations, needs to be made non-current and replaced with more specificity. So I hope I'm interpreting your question correctly, but if not, just chat again and I'll take another shot at it. Other questions?
What are the cases that we start the search for LLT from top to bottom?
All depends upon your level of comfort. If I asked you about multiple sclerosis, you would start in the neurologic because you know that that's where you're going to find it. If I were interested in finding a term like tetralogy of Fallot, I know that's a cardiac issue. And then I'd have to be worried about, is it going to be in congenital or is it going to be in cardiac? And that's how you're going to get experience with how MedDRA is organized, by where the answers to those things are. But some things are fairly straightforward. If it's a thyroid problem, you probably want to be looking in the endocrine systems SOC because that's where you're likely to find it, and you can do a drill down from top to bottom. If you're doing medication errors, I always say do top downs. And if the organ is very specific on where you're supposed to be looking, look in there. Occasionally you're going to get fooled, but if you have a good idea of what organ system's involved, that's where I would start. Bottom up, you have to just be very, very precise in your language because, again, if you spell it wrong, if you put in too many words and the words are not exactly a dead-on match for what's in MedDRA, you're going to get no results, not because you're, barking up the wrong tree, but because MedDRA had intake rather than ingestion, or MedDRA had neonate rather than baby. So that's why bottom-up searches are tougher unless you have some experience with MedDRA and the kinds of unique nomenclature it uses sometimes. Other questions?
Yep. There are 3 states that you mentioned that are not AE. You said death, disability, and then something else. Could you repeat what that third one was?
Hospitalizations. So again, they are outcomes typically. They are outcomes and seriousness criteria. You don't code a death as an adverse event. Now, because you asked the question, I'm going to give you a little bit more for your money. There is an exception to every rule. There is a situation where you would code death as an adverse event. And that situation would be a situation where the death is the only thing in the report. So if it said patient was found dead, if that was a report, patient was found dead, that's a death. And I told you not to code it as an adverse event, but that's all you have. And that's when your knowledge of MedDRA would have to kick in, because now you need to capture the fact that this person was found dead. And you would say, well, where am I going to find that in MedDRA? And you would know to look in general disorders, because at some other time in the past, you had no idea where to look. You looked through 26 other SOCs, didn't find anything, and finally stumbled on it at the end. But if I open up general disorders, here's an HLGT called fatal outcomes. And if I open that up, there's only one HLT, death and sudden death. And if I open that up, there is a term, PT, for death. And if I open that up, look at all the mechanisms of death that are actually found in MedDRA. Death by homicide, drowning, electrocution, all these things. But literally right here is an LLT found dead. So in that rare case where that's the only event reported in the report, you would need to go into general disorders and administration site conditions to find the LLT found dead. You code that, and unless you want to get fired, the very next thing you do is go out and find out what happened. You can't have a database full of found deads where you haven't tried to go and get follow-up information to understand the circumstances. But you have to do something with that report initially, and if that's all you had, that's what you're trying to capture. Other questions?
Someone just came in, so I'm going to read this one first. It says, okay, but suicide is actually codable and isn't found in fatal outcomes.
Suicide is a different issue altogether. And here's what I'm going to say to that person. I would advise you to take the advanced MedDRA coding webinar, because that's another layer of the PTC working document, or the PTC term selection document, that we specifically talk about. We talk about things like drug interactions and suicide and self-harm and what you do with those kind of things. The one thing I would tell you about suicide that is a big mistake that people make is to infer that a suicide attempt was made when it doesn't say so. If a report says suicide attempt, then you can call it a suicide attempt. If it says the patient took an overdose of pain medication and died, you cannot infer that that was a suicide attempt. This may be a person who had a pain problem and they were told, take 2 pills for your pain. And they said, well, I'm still in a lot of pain and I'm a big guy, so I think I could take 5. And this is a drug that has a very narrow range for toxicity. So they took 5, not with the intention of killing themselves, but thinking that they needed a lot of medication to help their pain. So for you to call that a suicide is reading more into it than you should have. But I would encourage you to look at that advanced, because those kind of questions are handled in that next one. And I think you sound like you're hungry for more knowledge than we just did here in the basic one. So I would encourage you to do that one. Other questions?
And then they put the little asterisk symbol. So it says, like, does the asterisk wild card still work?
To the best of my knowledge, it does work, but I don't even think that you need it. You can use truncated words.
If I have more questions later, how could I ask?
So the best thing to do is to, and again, I'll go to that last slide, the help desk. The help desk in general can help with most things. If it's something that clinical that needs to get kicked up a level, then there are people within the organization that will attempt with that. But here's what I'm going to say to you. No one in the MSSO is going to attempt to tell you how to code a report that you have in front of you. And the simple fact of the matter is, you don't want us trying to tell you how to code something that's in front of you. The analogy I would use is this. When I was practicing neurology, if I was walking out of the hospital one night and one of my colleagues, a nephrologist, walked up and said, oh, Dave, I see you're leaving. I have a question. I have this guy upstairs who's having a seizure. What should I give him? I don't know who would be sillier, him for asking that question, or if I was silly enough to answer the question. You can't answer a question like that without context. How old is the patient? What kind of medical problems do they have? Do they have any allergies? What type of seizure is it? So when you say to me, how do I code such and such? Without knowing your drug, without knowing its labeling, without knowing what your coding conventions are, without knowing the risk adverse nature of your organization, without knowing that you've already been in trouble with a regulatory agency because you've been deficient in your coding, that would be silly for me to do that. And if I was silly enough to fall into that trap and I said to you, well, I think you should code it with this, with limited information, and you put that code in your data and report that code 5,000 times, a regulatory agency is going to say to you, where'd you get this wrong code from? And you'll say, well, Dr. Richardson from the MSSO told me. And they're going to say, Dr. Who? And so I'm all about self-effacement when I understand that what this means is that I'm not slipping on a banana peel because I can't possibly know your drug as well as you do. So I'm just saying that to say, be careful what you try to use the help desk for, because they're not going to take care of that problem that's on your desk. Collectively, as an organization, you need to figure out how you want to handle that kind of report, especially if you're starting to have a lot of them that may end up translating into something that needs to be in your product label. Other questions?
When you mentioned ambiguity, you mentioned you code ambiguous cases as something. If you don't mind repeating it.
Here's what I will show you. And again, this one is covered in the advanced MedDRA coding as well. Unevaluable event. I'm going to show you where it is in the terminology. Okay, so we are in general disorders and administration site conditions. And now we're scrolling down under the HLT, general signs and symptoms not elsewhere classified. And we have unevaluable event. Now, sometimes you'll get a report where you just don't know what it is. The example we give, I believe, in the advanced course is the report said turn green. I don't know what turned green. Did the patient turn green? Did the solution turn green? Did the pill turn green? And no amount of hoping, wishing, and praying is going to give me any more information than that. So the best I can do in that situation is to code that as an unevaluable event and try my best to get an answer. That's a safe thing to do. And if you have a database that has 200,000 LLTs in it and you use unevaluable event 3 or 4 times, I don't think you're missing a signal. On the other hand, if you don't know how to use MedDRA and every time you're looking and you say, gee, I don't know where to look, I'll put down unevaluable event, and you try to submit a regulatory document where 40% of your database is the LLT unevaluable event, you're going to get laughed at and you're going to be told you need to do more work than that. So I would use unevaluable event very, very sparingly because it's really designed for those kind of situations where there's ambiguity or a situation like we just talked about where you're not quite sure what's being described and there's no way you can figure it out on your own what they meant by turn green. Other questions?
Yep. They said, are there terms for reports that state seizure-like symptoms or stroke-like symptoms?
So here's where you go get into trouble sometimes when you say stroke-like or seizure-like. You have to decide what it is that is being reported. And you need to also be very careful not to do more than you're told. So here is stroke, and I search, and I know it's in MedDRA, right? So there is stroke, and I go to browser, and it says it's in 2 SOCs. It's in nervous system and it's in vascular disorder. Which one do you want to see? And I click there, and it will take me to where it is in nervous system. Here is stroke, but look at all these other terms as well: recurrent stroke, stroke syndrome, CVA, apoplexy, apoplectic fit, et cetera, et cetera. You want to report what you have been told. And this is where you get into trouble sometimes. The report says the patient had double vision. He was weak on the left side of his face and the right side of his body. He was dizzy and his speech was slurred. He was diagnosed with a stroke. The diagnosis there is stroke, and you put down stroke as the term. But then you get somebody like me, a neurologist, who looks and says, oh, you're making a mistake there. That's clearly a brainstem stroke. You need to code that as a brainstem stroke. But that's all very nice, except it never says that in the verbatim. Even though all the anatomy and symptoms point to brainstem, you don't infer things other than what you're told. And the same thing is true with seizures as well. We have a wealth of seizure terms within MedDRA. You would assume that it's in the nervous system disorder SOC. And of course, when I start looking here, what am I looking for? I'm looking for seizures, and there's seizures including subtypes as an HLGT, and then various baskets, including complex partial, simple partial, and generalized. And under any one of these topics, you're going to find PTs and eventually find LLTs, some of which are non-current that you shouldn't be using. But here's grand mal convulsion, grand mal epilepsy. All those kinds of terms are in MedDRA. So I would be very careful in trying to overinterpret stroke-like or seizure-like. You need more specificity. Was it a seizure or not? Was it a stroke or not? I mean, that's what you're trying to do in an ideal world. Other questions?
One last one. Someone had asked, how do I pass the CMC test? And I advised taking the Certified MedDRA Coder Examination Prep webinar whenever that's offered. And they asked, are there any other ways that you could suggest to passing the test? So I thought that I might have you, Dave, if you could show our contact page, and possibly they could attend face-to-face webinars or join our new WhatsApp group. Maybe that could help, or I don't know if you personally have other suggestions for this attendee.
Okay, so I'm going to go to the website, go to the homepage, and under training, under offerings, is something called the Certified MedDRA Coder Exam. This is an exam that is offered that allows one to get a certificate saying that you're a really, really good MedDRA coder. It's a timed examination. It's 90 minutes, I believe, and you have to answer 55 questions, and you have to get 70% of them right. Here's what I'll say about that. If you can pass the CMC examination, you're a very good coder, because the exam is designed to be difficult. You have to really have a good grasp to be able to answer these short verbatims and the narratives as well. When you ask me the question, how do I pass the exam? I'm not trying to be cynical in any way. It's you can't pass the exam if you don't know a lot about coding. So if you have been a coder for less than a year, I think the chances of you passing the CMC exam are pretty slim. In fact, when people ask me if I know nothing about MedDRA at all and begin to use it, how long does it take for me to become proficient? I would say you need to be in MedDRA at some point of 5 days a week for at least 12 to 18 months before you are comfortable with it. And taking a certification exam short of that is really going to be, in my opinion, a waste of your money. So if the person asking has attempted to take the exam before and not pass the exam, the only thing I can infer about that is that even though you think you're an experienced coder, you don't know enough about MedDRA. And I would say if you haven't taken all of the webinars, take the webinars. And if you haven't done the LMS training system, you might want to go through that and make sure you do the modules on special circumstances like pregnancy, etc. And when we offer things like our Let's Code Together webinar, you might want to do that one as well, because that's a webinar where there are actually it's a live discussion of actual examples where collectively 2 of our colleagues will describe a verbatim and talk you through how to get there. So there's no easy answer for it. You need to know the PTC document backwards and forwards, because that's what the CMC examination is based on. So if you haven't read the points to consider term selection document from cover to cover, that's the very first thing I would do, and then do this additional training. And if your actual use of MedDRA is limited and having used it for only a few months, it's probably too early in your career for you to be trying to get that certification. Anything else?
That is it. You've answered them all.
All right, folks, I want to thank you again for your time and attention. I hope I piqued your curiosity about a number of things related to MedDRA. Tried to point you to some resources that are there as well. Again, communicate with us. If you think we're missing the boat with certain terms, send us a change request. We listen. Like I said, the vast majority of new terms in MedDRA came from you. They didn't come from us. And I would encourage you to keep with your MedDRA journey because, as I said to you, every single day, something new is being put in. And even though I know what version 28.1 looks like, next week they may be putting in something new that when I open up version 29, I didn't know it was in there. So that would be my only other caveat there. So again, Dr. Dave Richardson, I'm thanking Sarah for her help today and enjoy the remainder of your day.